What you don't know is the pass rate of any Royal College is very low. It is not even exceeding the 50%, okay? This means that you will find a paper of fail, 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 pass, fail, 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 pass. What is raising your pass mark really, which is making you 70 or 80% pass rate, is the recalls. And not any recalls, because you can find a lot of recalls in a lot of resources, but not all answered correctly and not answered with very correct explanation, because anyone can convince you that this is correct, but this is not according to the NICE guidelines, so it might not be correct. So the game is to have repeated exam recalls, and these recalls will represent extra 30% or 20% of your pass. Like if you will get 60% with your study, with the recalls, you can get 80%. If you are going to get 70% with the recalls, you get 90% or 85%. So the recalls are really very, very crucial, very, very important to have recalls, okay? And to have it 100% correct. So you can find me solving these recalls, and this is what's mentioned by some people that got 90% with me, like someone called Osman. During his record, he told me that we found this recalls in multiple areas with multiple solutions, with multiple options answered, not like you said. But because we trust you, I was going to select what you said. So their answer was correct in the exam, and they got 90%, 89%, like Walid Shinouda got 90%, Walid Ambar got around 89 point something, so 90%. So the recalls are very, very important to have it correct and to have it very correct as well. So you can go and subscribe a lot of recalls, and these people came to solve recalls with you, but the recalls needs to be sorted correctly. Okay, so Dr. Mustafa.
Assalamu alaikum wa rahmatullahi wa barakatuh, Mr. Rita.
Salam wa rahmatullahi wa barakatuh. Yalla, go on.
A 45-year-old woman present to the emergency department with shortness of breath, pain on deep breathing, and fever for 1 day duration. 12 days ago, she had varicose vein surgery. On examination, she had a sinus rhythm with a pulse rate of 110 beats per minute. Her blood pressure is 130/90, and her temperature is 38. Pulse oximetry shows a saturation of 92. Chest examination is normal. CTPA demonstrate a pulmonary embolism. What is the most appropriate treatment? Since the patient is stable, I will go with low molecular weight heparinization.
Okay, low molecular weight heparin, excellent. Next one.
60-year-old man with ischemic heart disease present with bilateral gynecomastia with one of the following drug is most likely to have caused this.
Do you remember DISCO? DISCOs or DISCO is digoxin, isoniazide, spironolactone, cimetidine, estrogens, and stilbosterol. DISCOs is a mnemonic, okay, Dr. Mustafa, is a mnemonic showing that what is the drugs causing gynecomastia. So from DISCOs, what is the drug here causing gynecomastia? Digoxin, isoniazide, spironolactone, cimetidine, estrogens, and spironolactone. Next one.
70-year-old man with carcinoma of bronchus presented with blurring of vision, headache, and nausea, particularly in the morning. Which of the following is the most appropriate treatment? The most appropriate treatment here would be dexamethasone.
Okay, when you have a lung cancer with blurring of vision and headache and nausea and morning vomiting, this is pointing us to think about the metastatic disease to the brain, and metastatic to the brain, dexamethasone, don't forget. Okay, so brain mets, dexamethasone. Okay, what about Zadig's operation? What you are going to use for Zadig's? Which type of analgesia you are going to use with Zadig's operation?
Mm,
Ring block via lidocaine alone.
lidocaine.
Ring block. What is Zadig's operation? Do you know?
Uh, mhm.
Zadig's operation. Anyone knows what is Zadig's operation? It is, when you have ingrowing toenail, you do wedge resection of the nail, right? So
Yes.
this is called Zadig's. Why you don't use Zadig's operation using lidocaine plus adrenaline? Why lidocaine alone? Because we
Because in
don't
that
use
is
adrenaline in the end arteries like penis and the uh, fingers, but we use it in the scalp to, because of profuse bleeding. What about pancreatic cancer with severe back pain and stuff like that, and not controlled by Oramorph and other anti um, uh, other
celiac,
analgesic medication? What you are going to do?
celiac block,
Celiac block, nerve block. Okay. Uh, bone metastasis. What are you going to do?
radiotherapy.
Radiotherapy. Okay. So again, any minor procedure, you will start in the first step in WHO ladder, pain control ladder. You will use paracetamol alone. If not relieved, you will step up using non-steroidal. But please know that non-steroidal are not used in general surgery anymore. Yes, we use it, but it is not beloved. It's not preferred by the surgeons. Why? Because of the risk of ulcerations and kidney disease. So we are away from, because post-operatively the pain already in stress. So they use Oramorph. About flail chest or flail chest or flail segment, the idea is having a segment that is separated from the chest, and the pain will be severe. So you need to think about pain. But before think about pain in flail chest, please think A, B, C, D, E. Therefore, if the patient having any signs of respiratory failure or any cyanosis or any stuff like that, please. Okay, so please use A, B, C, D. Airway, so think about intubation, high flow oxygen, and in the D section, you will give analgesia using intercostal nerve block or epidural if respiratory comorbidity is associated, or patient-controlled analgesia. Okay. But in pancreatic cancer, think paracetamol, Oramorph, then nerve block, which is celiac ganglion block. Okay, next one.
A slightly overweight 13-year-old boy present with a 3-week history of right hip pain and limping. On examination, the hip moves into external rotation when flexed. Which of the following is most likely diagnosis? This is a classical history of Sufi, slipped upper femoral epiphysis.
Not necessary to tell you it is obese or no, right?
Yes.
Okay, can you tell me more about slipped upper femoral epiphysis if you remember and concentrate?
Yeah. In
What
slipped
is
upper,
the age of the presentation?
usually adolescent.
Yeah, but we say 8 to 16, 8 to 16. Risk factors, obesity, and the problem is unstable growth plate. This is the femoral physis. Due to mechanical overload, like in obesity, or growth spurts causing rapid cellular proliferation in the growth plate, leading to slippage of it and the change in the vasculature. So this will lead to slippage of the femoral epiphysis. And the symptoms will be pain in the groin, hip, thigh, or ipsilateral knee without any trauma. without any trauma. And the painful limping, okay? Do you know what is Dreeman sign? Anyone know what is Dreeman sign? Anyone
Yes.
knows about Dreeman sign or Dreeman sign?
External rotation.
So the Dreeman sign is positive if an unavoidable passive external rotation of the hip occurs when performing a hip flexion. This what happened now. This what happened in the question called Dreeman sign. Dreeman sign, I will write it for you. Okay, and this is what came for exam before telling them. Okay, this is the Dreeman sign. Okay, so it is unavoidable passive external rotation of the hip when you perform hip flexion. Okay, so when you flex the hip, you will find it directly went lateral, externally rotated. Is it clear? Okay. Next.
A patient with locally advanced pancreatic cancer develops persistent back pain. Which of the following is the most appropriate treatment? NS, just the following. Yeah. Celiac nerve.
The most appropriate.
Celiac nerve.
Again, they don't use non-steroidal anti-inflammatory drugs. They don't like it. He's asking about the most appropriate. Persistent back pain. What is the most appropriate? If auramorph here is going to be suspicious answer. Okay, so we will go and I will go according to the previous experience from the all exam. We will go with celiac block. Next.
50-year-old woman sustained displaced distal radial fracture. This is manipulated under anesthesia and treated in a cast for 6 weeks. After 3 months, she returns to the fracture clinic with painful and limited pronation and supination. Which of the following is most likely diagnosis? This would be malunion.
Okay, so the difference between Krebs and malunion. Krebs called, what is the name of the Krebs? It's called pseudox atrophy or complex regional dystrophy. There is type 1, no underlying single nerve injury, and it's known as reflex sympathetic dystrophy. Reflex sympathetic dystrophy. And type 2, this is there will be underlying nerve lesion identified, and this is causalgia. Causalgia. Okay, so there are two types of Krebs. Reflex sympathetic dystrophy without underlying single nerve lesion. Type 2, there is a single nerve lesion and caused by and the cause is named as causalgia. The patient presents after an initiating event, okay, like trauma, minor trauma, surgery, or immobilization even, or myocardial infarction or whatever. Okay. Symptoms more than 6 months duration, such as edema, changes in the skin blood flow, abnormal motor activity, allodynia, and hyperalgesia. Hyperalgesia, so motor, abnormal motor, abnormal skin blood flow, edema, and allodynia, and hyperalgesia, exaggerated pain feeling. Symptoms are out of proportion to the initiating event. So the event is very minor, and all of this are resultant of underlying sympathetic dystrophy, no nerve, or underlying nerve lesion. This is causalgia. Okay, so there will be severe patchy osteopenia on the X-ray and soft tissue swelling with soft tissue atrophy and subperiosteal bone resorption and preservation of the joint space. Okay? So this is the X-ray, and the MRI is the best to demonstrate the patchy bone marrow edema and soft tissue edema and enhancement with skin thickening, joint effusion, and synovial hypertrophy and muscle atrophy in the later stage. Have you found all of this signs of complex regional dystrophy in this question? The answer is no. Okay. So there is no disturbance of the sympathetic nervous system. There is no other extra joint manifestations or extra bone manifestations or pain manifestation. There is multiple manifestations. There is no that in this question. So it's not complex regional dystrophy. It's simply malunion. Okay. Next one.
3 days after isolated head injury from a fall on the right side, a 76-year-old woman is admitted for drowsiness and confusion. There are no localizing signs. A CT scan is most likely to show right side depressed thing. Blood in the subarachnoid space. Okay. Cerebral atrophy with a subdural collection on the left side.
So this is 3 days only after an isolated head injury. 3 days only from a fall on the right side. Okay. A 76-year-old woman is admitted for drowsiness and confusion. There is no localizing signs, and CT is most likely to show what? It is contralateral something. And Roa and Z and Ismail, what is this known as? So no signs of infection, no fever, no any systemic manifestation. Crescent intracranial hematoma on one side will give localizing and lateralizing signs, so it is A is wrong. An expanding extradural hematoma on the left side, it is the same, not extradural, okay? Because there is no lucid interval or anything to blow to the cheek or anything. Blood in the subarachnoid. The subarachnoid is immediate headache and then collapse. Okay, and this is not the condition. But what is this caused? What is the cerebral atrophy after 3 days? What is this called? Anyone knows? Anyone went to USML? Anyone went to USML know what is this after 3 days? Okay, there are two questions now for you. What is diffuse axonal injury? What is the diffuse axonal injury?
Diffuse.
Which is not our case. What is diffuse axonal injury? Anyone studied the question posting session? I will give you example. There is a 40-year-old lady came to the A&E with RTA, and there is a car hit her at high speed. And they do ABCDE and CT of the head unremarkable, but she's unconscious and hemodynamically stable. MRI demonstrates multifocal hyperintensities in the splenium of corpus callosum. Okay. So simply, it is a type of traumatic brain injury secondary to a blunt injury to the brain. And it is generally found in severe traumatic brain injury and considered in patients with a Glasgow Coma scale less than 8. Okay. Due to we said high motor vehicle accidents, and the symptoms is headache, dizziness, nausea, vomiting, loss of consciousness, and coma. And the CT will give small punctate hemorrhages in the white matter, and also initial head imaging study in head trauma. There will be CT, but if not demonstrating anything, we will do MRI. So the MRI is a modality of a choice in diffuse axonal injury. Okay, so this is going more with cerebral atrophy. But what type after 3 days? Still, we haven't answered the question. Because subdural, the CT will give crescent-shaped hemorrhage. Subarachnoid, hyperdensity in the subarachnoid space by CD head. Epidural, there will be lens-shaped and biconvex hyperdensity if you studied neurosurgery question posting. I'm waiting for you. Okay, so after 3 days, if you study the question posting session, you will find that it is not of anything we studied. Even if you are going to tell me this is subdural hematoma, I told you subdural hematoma is associated with a chronic. Subdural hematoma, a chronic one, is associated with cerebral atrophy. But this is a subdural. This is the answer here, that this is subacute subdural hemorrhage, subacute with no anything. But this is just incidental finding. This is the trick was last year or April 2018. So don't read single letter from the or single word from the sentence. So the answer started here, subdural collection on the left side. Okay, because this is called subacute subdural hemorrhage. And I will tag you in the question posting session from when we said subdural, we said that there is a subacute type and it is the same given in the question. Okay, so subdural, we said acute, subacute. Yeah, see here, this is subacute. I tagged you on the question posting. So it is just the answer started here. This is the trick. So none of what you've said. Okay, so cerebral atrophy, and the answer is E. Next one.
A 40-year-old man develops
Yes, yeah, it is.
high output fistula following multiple jejunal strictoplasties and an ileal resection of the Crohn's disease. Which of the following is the most appropriate form of nutritional support? I'll go with total parenteral nutrition.
TPN, okay? In your exam, a lot of people got confused of the nutrition cases, okay? The indication of nutrition is intestinal failure. So it is not required from you to decide which is the most appropriate, but it is TBN. We can revise now on the nutrition cases. I will ask you about oesophageectomy. What is the nutrition of a choice?
Jejunostomy?
Yes, jejunostomy and esophageal perforation.
Total parenteral nutrition.
TBN. And for enteral therapy for RTA patient lasting less than 4 weeks.
That is nasogastric failure.
Nasogastric. And if I told you it is long term, it is going to be long term.
Pig.
Percutaneous endoscopic gastrostomy. Okay. And if I told you there is patient post-op, okay, in the ICU, and going to have, it is in the ICU, it is critical case post-op, low anterior resection. Due to the multiple cardiac comorbidities, the perioperative assessment asked to put him in the ICU. And I give you options of nutrition, TPN versus patient-controlled analgesia. Because the patient is day 10 until now not recovered, not well recovered. So what are you going to think? Patient-controlled analgesia versus TPN.
TPN.
Why not patient-controlled? No, I'm talking about the pain management. Patient-controlled analgesia versus like epidural or long-term pain management. So the problem in the patient, it's not the nutrition cases, it's about pain management. So what I'm going to say is, what I mean is, when you have a patient in the ICU, so you should expect that the patient will not be able to press on the patient-controlled analgesia button because he might be comatose. So just to remember that in this case is going to be not patient-controlled analgesia for the patient in the ICU. Next one. Anyone here? You finished 9 questions. Brianda, anyone raising? Okay, Brianda, go on.
Hi.
Thank you, Mustafa.
Can you hear me?
Hi. Yes, of course.
Great. A 3-month-old boy who was born prematurely presents with a tender, irreducible swelling in the right groin. Which of the following is the most likely diagnosis? Okay, so for the age, tender and irreducible swelling, I would go, and most common, I would go for C, indirect inguinal hernia.
Okay, what is the cause of indirect inguinal hernia? Or oblique, it's called indirect or oblique inguinal hernia.
Well, in this case, I'm not very sure, but normally it's an abdominal wall defect.
Yes, it is abdominal wall defect, but I need you to know that there is 2 types of hernia. If you draw, notation. This is the midline of your tummy, and this is the symphysis pubis, and this is the pelvis here, okay? And here I'm going to put the inferior epigastric vessels, okay? Here like that, okay? So we have 2 types of hernia, okay? 2 types of hernia. Direct one, this is the tinea alba, okay? This one is the linea alba, okay? So if I told you there is a defect in the Hasselbalch triangle, what is Hasselbalch triangle? Hasselbalch triangle is bounded by linea alba medially, inferior gastric vessels laterally, and the other part of the triangle is the inguinal ligament. So anything happening in this area is called direct inguinal hernia.
Yes, sir.
Direct inguinal hernia, which is medial to the inferior epigastric vessels, okay? And it is what defect in? Where is the defect of direct inguinal hernia? Yes, it is anterior abdominal wall defect, but where?
In the transversus.
Fascia transversalis.
Yes.
Okay. Fascia transversalis. Okay. So again, the types of the hernia. This is the direct one, bulge through the Hasselbalch or inguinal triangle, direct through the abdominal wall due to transversalis fascia defect through external or superficial inguinal ring. Medial to inferior gastric artery, covered only by external spermatic fascia, most commonly on older men. This is the direct. Okay, this is the direct. And also lateral to the pubic tubercle. Okay, lateral to pubic tubercle. This is till now is the direct. Okay.
Yes.
But indirect or oblique, you remember the spermatic cord in male or the round ligament in female. There is some sort of direct inguinal ring. Where is the surface anatomy of direct inguinal ring? Where is the surface anatomy of direct of deep inguinal ring?
Is the midpoint between the aces and the symphysis pubis along the along the inguinal ligament?
No. No, not MIP. No. MIB is between anterior superior iliac spine and symphysis pubis. Okay, this is the surface marking of femoral artery. Because it is artery, it is MIB. It is a region between symphysis pubis to anterior superior iliac spine. But the ligament itself, the midpoint of inguinal ligament, where is the attachment of inguinal ligament? Do you know? The inguinal ligament from pubic tubercle until anterior superior iliac spine. And the midpoint of inguinal ligament, half an inch above it, there will be the deep inguinal ring. Half an inch above the midpoint of inguinal ligament. But the MIB, I'm going to have another color for mid MIB. The MIB mid-inguinal region point from symphysis pubis until anterior superior iliac spine. This here is the femoral artery, because it is MIB, femoral artery MIB, okay? So the MIB is the femoral artery, mid-inguinal point from symphysis pubis to anterior superior iliac spine. But half an inch above midpoint of inguinal ligament, because it is ligament and this is hernia, so they are linked together. This is a mnemonic to remember. Again, I will make it the same color. From anterior superior iliac spine to the pubic tubercle, this is the attachment of inguinal ligament. Midpoint of inguinal ligament, half an inch above it, this is the deep inguinal ring, okay? The cord of, or the round ligament in the female, or the spermatic cord is coming from the back, okay? From the back. So how it will descend? It will descend from the back through the deep inguinal ring and go superficial until the superficial inguinal ring, and then descend in the testes. So this is the line or the course of indirect or oblique inguinal hernia, okay? So if there is a hernia here, it will be what? It will be lateral to the femoral vessels and can descend to the scrotum because it is oblique. So this is the indirect, and it travels the entire length of the inguinal canal following the descent path of the testis and enters the internal inguinal ring, deep inguinal ring, lateral to inferior epigastric vessels, and exits the external inguinal ring and may enter the scrotum, covered by all layers of the spermatic fascia, and most commonly seen in male infants. Male infants. Why? Due to PPV, patent processus vaginalis.
Okay.
Okay?
Okay.
Okay. If I told you there is 40-year-old female lady coming with by inguinal swelling, and this the location of the swelling on examination is below and lateral to the pubic tubercle, and the swelling is so painful. What is this?
Femoral hernia.
Thank you. Okay. So femoral hernia in female is subject to have strangulation because of the risk of strangulation and narrow neck. Okay.
Okay.
Next one.
An otherwise healthy 5-year-old boy presents with 6 weeks history of a minor, painless, intermittent, bright red rectal bleeding with no associated disturbance of bowel habit. Which of the following is the most likely diagnosis? Okay. So I would say D, juvenile rectal polyp.
Juvenile rectal
Polyp.
Excellent, Brianda. Keep going. Brianda, don't feel late. If you just started today, continuously doing recalls and going back to the question posting MRCS and pastis, I will, like 2 of your colleagues in the UK, Imogen and Eleni. I give example with the same case. Lady in the UK, very busy, and court trainee. Both of them passed. Eleni was suspicious that she told me I'm going to fail. I told her just wait the results.
Okay.
She got 81%, I think, and Imogen was going to fail and started only studying with the crash course, and she got 84%. So we need to do with this exam. Go on, next one.
Okay. A 56-year-old woman ventilated in intensive care has increasing oxygen requirements 1 day after elective aortic aneurysm repair. Her pulmonary capillary wedge pressure is 20 millimeters of mercury, and she has obvious bilateral diffuse opacities on chest X-ray. Which of the following is the most likely diagnosis? So here I would doubt between the first and the last. She has some traits of acute respiratory distress syndrome, but also this could be pulmonary edema secondary to heart failure, especially after an aortic aneurysm repair. I'm not very sure. I would be doubting between the first one and the last one.
We listed in the question posting the difference between ARDS and acute cardiogenic pulmonary edema. Acute cardiogenic pulmonary edema and ARDS, okay? So acute respiratory distress syndrome is, what is the problem? The kidney, the lung is the problem, or the heart? The lung itself, okay? So first I will talk about ARDS, and I will give you very nice example, okay? So acute respiratory distress syndrome. The problem is not in the heart at all. The problem is a disease in the lung. So everything is coming from the lung. Okay, you will never forget this. And I have told last exam. I have discussed about that. So it is inflammation of the lung due to acute hypoxemia. and there will be global affection of the lung, bilateral radiographic infiltrates. And there is what's called Berlin definition of RDS. It is acute onset within 1 week of a clinical insult, and bilateral infiltrates without an alternative explanation. Respiratory failure not caused by cardiac cause or volume overload, and hypoxemia. Okay, so this is again hypoxemia, respiratory failure not due to cardiac cause, bilateral infiltrates, and acute onset within 1 week of the insult. There is severity, mild, moderate, severe, according to the PaO2, FiO2 ratio. What is FiO2? It is the fraction of inspired oxygen. Okay, so this ratio will determine the ARD severity. PaO2 divided by FiO2 between 200 and 300, this is a mild. Moderate PaO2 FiO2 ratio is 100, 200. This is moderate. And severe is if you have PaO2 divided by FiO2 ratio less than 100. The etiology is pneumonia. This is the most common risk factor. Or aspiration, or contusion, or acute pancreatitis, or sepsis. Sepsis, acute pancreatitis, pulmonary contusion, aspiration, but the most commonly is pneumonia. So it is inflammation to the alveoli and increased pulmonary permeability. Capillary permeability leads to exudative phase and the proliferative phase of immediate destruction of the epithelial interstitial endothelial barrier of the lung, leads to extravasation of the fluid. That's why we should compare it with the pulmonary edema. And lastly will be fibrotic phase, affecting the gas exchange due to alveolar collagen fibrosis. The presentation is dyspnea, tachypnea, tachycardia, diffuse crackles. So dyspnea, tachypnea, tachycardia, diffuse crackles. Making the diagnosis based on Berlin criteria. The chest is the initial imagery of workup, and as you see here, there is what is called PaO2 ratio, or pulmonary capillary wedge pressure. Okay, in this case, we need to know what is pulmonary edema to determine what is the difference. So if I told you this is ARDS, the infiltrates homogeneous, bilateral, and no pleural effusion and no curly B lines. But in the cardiogenic, pulmonary edema will be problem in the heart, like myocardial infarction or left ventricular dysfunction. So effusion will be present, and the hypoxemia will be responsive to oxygen in the cardiogenic pulmonary edema. But in the non-cardiogenic, because the lung itself is diseased, the problem will be the hypoxemia will not be responsive to oxygen. Okay. What else is in the difference between both of them? The BACWB. I will go draw the heart now. It's just simple drawing to the heart. This is the heart. Okay. Oh no, I don't think this is heart. Okay. Yeah. This is, if this is the heart, okay, and this is the lungs, okay. Okay. If you have a problem in the heart here, in the left atrium chamber, and the venous return will come from here, from the lung. So if the heart got a problem like left ventricular dysfunction, the left atrial pressure will increase, and then will reflect this into the lung, say, oh, the lung, please don't drain into me because I am diseased. So the lung will start to have edema. Now it is called cardiogenic pulmonary edema, CPE. Okay. Cardiogenic pulmonary edema. If you give oxygen to this patient, will be responsive because the lung is fine. It is just edematous from the heart problem. It is cardiogenic pulmonary edema. Okay, if you will measure what is called BCWB, what you will find?
You mean the pressure of the left atrium? A
The
reflection of
pulmonary capillary wedge pressure.
So you would find a lower wedge pressure. Is that what you mean?
No, the pulmonary capillary wedge pressure is indirect estimate to the left atrial pressure, just to determine first or define first. So this is the left atrial pressure, left atrial pressure. So when you measure the BCWB,
Yes, so in acute respiratory distress would be lower and in edema would be high.
No. In the cardiogenic pulmonary edema, this will be high, okay? But it is normal in the ARDS.
Okay.
Okay, so in ARDS, BCWB is indication or it is a reflection of left atrial pressure. I'm sorry, the pen is not working. That's why I'm drawing by the mouse. Okay, so the left atrial pressure reflected on your measurement to the BCWB, the pulmonary capillary wedge pressure. Okay. Measured by inserting Swan-Ganz catheter into the peripheral vein, jugular or femoral, and advancing the catheter into the right atrium, right ventricle, pulmonary artery, and then a branch of the pulmonary artery, which is going to reflect what? The left atrial pressure. If it is high pressure, this means that the heart left atrial pressure is high because this is cardiogenic problem. There is dysfunction. The heart is not able to pump to your body because of its dysfunction. So the pressure will increase, will be reflected here. And there is there will be cardiogenic pulmonary edema. But if this lung leaves this patient, come to another patient. If this lung due to sepsis or pneumonia or acute pancreatitis, having severe edema due to interstitial pneumonitis or what's called disturbance of the capillary permeability of the pulmonary epithelium, there will be edema due to lung itself problem, okay? So the BCWB is not affected. It is normal, below 18 millimeter mercury, okay?
Okay.
Because the problem in the lung itself, not the heart. So the BCWB will never have a problem.
So it would be pulmonary edema secondary to heart failure.
Okay, so you get the point now.
Yes. Thank you.
Thank you. So it is high, so it is cardiogenic pulmonary edema. It is clear for all or no? Is it clear for all of us? Tell me in the chat. Normal in ARDS? I know I can tell them normal in ARDS, but I'm just trying to make them understand, not to forget. Okay. Next one.
Okay. Shall I continue?
Yes, go on.
Okay. A 75-year-old man is scheduled for abdominoperineal resection for a rectal carcinoma. As part of the enhanced recovery program, he was given a carbohydrate drink the night before surgery. How does preoperative carbohydrate loading works to improve the outcome of surgery? So it improves nitrogen balance and reduces insulin resistance, the third one.
Okay, so it will improve the nitrogen balance and reduce the insulin resistance. This is a perioperative carbohydrate drinks, preoperative, 2 hours pre-op in the enhanced recovery program. Next one.
In the UK, the National Institute for Health and Care Excellence Guidance recommends that if a person has had a blood transfusion, they should be informed that they can
what?
Sorry, I'm reading. No longer be a blood donor.
Why? What is this called?
Because they can have
Prion disease?
yes.
Okay, what is prion disease? Can you tell us? Because I don't understand the idea, really. I read it, I know the nice guidelines, but I need to ask a hematology doctor or stuff like that. So if you understand it, let me know. It is protein infection. Okay, why?
I'm not an expert, I'm not very sure, but I think that prions are microparticles of a type of bug that can remain in the cells of the blood for longer periods of time than the other toxins. So if they have been identified in one sample, they can contaminate any further samples because they're very small and very transmittable. That's my basic understanding, but I'm not sure.
Excellent. Okay. So I tagged the nice guidelines that no longer to be a blood donor.
They basically corrupt other samples. This is what I understood, but I'm not very sure.
So if I transfuse the blood, if a person has a blood transfusion for him, right?
Mm-hmm.
So I had the blood now. So I couldn't be a blood donor for anyone?
If you have had a blood transfusion reaction, no, you can't.
I can't. Why? Why I'm asking?
I'm not sure, but I
read it from the NICE guidelines, but I tagged you as well from the NICE guidelines for what's called the Creutzfeldt-Jakob disease.
Mm-hmm.
Causes brain damage. So currently you cannot give a blood if you have had a blood transfusion. This is precautionary measure to reduce the risk of a serious condition called variant Creutzfeldt-Jakob disease being passed on by donors. Okay, so no problem, but you couldn't be due to this disease. Okay, next one.
A 50-year-old woman presents with a 1 centimeter diameter, pigmented, crusting, bleeding lesion on her back, clinically suggestive of a malignant melanoma. Which of the following is the most appropriate diagnostic procedure to be performed? I would go for a excisional biopsy.
Excisional biopsy.
Yes.
Or punch biopsy.
Well, for a large lesion, you would do a punch or incisional biopsy. For a small lesion, you would do an excisional biopsy. In this case, it's 1 centimeter, so I would say that's small. I would go for excisional.
Okay, excellent, thank you. Next one.
Okay. A 23-year-old asthmatic man is admitted with a bilateral fracture of fibula and tibia following a road traffic accident. He is on 15 milligrams of prednisolone daily and is to undergo surgery the following day. Which of the following regimes should be implemented?
So you remember the steroid cover?
Yeah, so you would increase the steroids on the day of surgery and for 1 month following surgery.
So what is the answer?
The fourth one, or D.
Not E? So this is bilateral hip fracture. What is, can you look at the group? Look at the group, all of us. There are two types of, three types of surgery, minor, moderate, major. My major surgery is you should have usual dose of steroid pre-operatively and then 25 milligram of hydrocortisone IV at induction, followed by 100 milligram IV every 8 hours for 48 to 72 hours. بالعربي هاخد الاسترويد بتاعت النهارده وهاخد 25 مللي جرام في الاندكشن بتاعت التخدير، وبعد العمليه هاخد 100 مللي جرام وريد 3 مرات في اليوم لمده 3 ايام. 100 جرام 3 مرات في اليوم لمده 3 ايام. Okay, this is if it's major surgery. So increase the steroid on the day of the surgery and for 3 days post-op.
Okay.
So I would go with E as well. Increase the steroid on the day and for 1 month, no. Reduce, no. Omit on the day of surgery, then continue normal, no. Continue normal. So it is according to this. It's more than 10 milligram. It is major surgery. So usual pre-op plus 25 milligram plus 100 post-op for 3 days, 48 to 72 hours. Next one.
Okay. A 72-year-old woman who was treated for breast cancer 20 years ago presents with tiredness, constipation, back and chest pain. Examination reveals localized tenderness over thoracic vertebrae and anterior ribs. Her pulse is 110 beats minute and blood pressure is 90 over 60 millimeters of mercury. An ECG shows a shortened QT interval. Her biochemistry results are as follows. Chest X-ray shows lytic lesions in the left anterior third rib and fifth thoracic vertebra. Which of the following treatments should be administered first? Okay. Well, so here we can see an hypercalcemia. So the first treatment should be 0.9% sodium chloride.
So what is the treatment of that?
Well, the question asks what should be administered first. So in hypercalcemia, you would start with fluids and then you would start with treating the origin and then doing pamidronate or alendronate or calcium chelates, basically.
Okay, can we talk, all of us, can we talk a little bit regarding the, what's called the electrolyte imbalance? Okay, can we? Okay, I will start in 1 minute. Okay, so simply we have hyponatremia and hypernatremia. The normal sodium is 135 to 145. The hyponatremia is when you have serum sodium less than 135 millimole per liter. There is pseudo hyponatremia, like in case of increased something like lipids or glucose or proteins. Hyperlipidemia, hyperglycemia, and hyperproteinemia, like in multiple myeloma. Or when you have hypervolemic hyponatremia, congestive heart failure, nephrotic syndrome, cirrhosis, and renal insufficiency. There is high volume of water due to kidney, heart or lung, kidney by nephrotic, liver cirrhosis, heart, congestive heart failure, or renal insufficiency. So this is hypervolemic hyponatremia. Or hypovolemic hyponatremia in vomiting, diarrhea, burns, sweating, cystic fibrosis, and thiazide diuretic and AC inhibitor use, and also low mineralocorticoid, adrenal insufficiency. Why? Because the function of the adrenal is salt water retention and potassium loss. When you have adrenal insufficiency, Addison, you will have what is called a low, yeah. Okay, so don't forget Addison's, and very important, Addison is adrenal insufficiency or eupvolemic hyponatremia. eovolemic hyponatremia. Eovolemic in psychogenic polydipsia, hypothyroid, and sciatica. And also diuretic and ACE inhibitor use can be eovolemic as well. So again, eovolemic in sciatica, syndrome of or SIADAH, or syndrome of inappropriate ADH release. The presentation is nausea, malaise, seizures, coma, confusion, and until arrhythmias and cardiopulmonary arrest. Hyponatremia is very severe. Please assess the volume status and serum electrolytes and manage accordingly, because the underlying cause is usually the cause. Urine electrolytes, urine osmolality, and serum osmolality. And if it is asymptomatic, just simply free water restriction. Okay, the total input for a patient should not increase 1 liter per day. Free water restriction. Moderate hyponatremia, give IV normal saline and give some loop diuretics, which might be added. For severe hyponatremia, you can give hypertonic 3% saline. This is hyponatremia. Hypernatremia, when you have serum sodium above what? Anyone remember? Hypernatremia. If you have sodium above what? 145. Excellent. So in this case, you have higher sodium. Which is more severe or more risky, hypo or hypernatremia? Hypo. Okay, so, and for the hyponatremia, don't correct sodium rapidly for fear of central pontine myelinosis. Okay, correction not more than 12 milli equivalent, as you said. But the hypernatremia, if you have osmotic diarrhea or osmotic diuresis like in diabetic ketoacidosis, poor fluid intake, diuretic use, vomiting, diarrhea, all of this can lead to hypernatremia, which is you lose fluids only, but the sodium is still in your body. So your concentration of sodium is high because your body have no water. The same manifestations, and don't forget hypertonic sodium gain, central and nephrogenic diabetes insipidus, because these are losing water. And osmotic diuresis, this means that you are losing water, so it is hypernatremia. Assess the volume status and assess serum electrolytes and the treatment underlying cause. And please give IV 5% dextrose in water, T5W. Okay, this is the hypo and hypernatremia. We are going for calcium and potassium, which are more important in your exam. Hypokalemia, the normal of potassium is 3.5 to 5, or 3.5 to 5.5, whatever the normal range, which is usually given in your exam. Okay? Please bear with me, I'm going to finish. Just remember that the hypocalcemia is potassium, hypokalemia is potassium below 3.5. When you know that your potassium is managed by internal imbalance and external imbalance, okay? Simply the internal imbalance is your intake, okay? When you take something, this is caused internal imbalance, external imbalance. But when there is a sweating and when there is diarrhea, okay, or when there is anything else like cellular balance between the vascular and intracellular and extracellular compartments. This is called internal balance, okay? So simply you have hypokalemia due to use of something like insulin or hyperglycemia. Why? Because simply 98% of your potassium is inside the cell, and only 2% of your potassium in the blood, okay? So this is the intracellular potassium, because potassium is the main intracellular cation, okay? So the insulin function is to take the potassium outside inside the cell, so it will cause hypokalemia or hyperglycemia that stimulate insulin, or beta adrenergic agonists. Okay, beta adrenergic agonists will work on introducing the potassium inside the cells, causing hypokalemia or alkalosis. Why alkalosis? Because simply you have some channels to replace potassium and hydrogen, hydrogen and potassium. Okay, so when you have hypokalemia, when you have alkalosis, so this means that you have high pH and low hydrogen in the blood. Low hydrogen in the blood, so the balance or homeostasis, the hydrogen will be extracted from the cells to go to your blood to try to compensate for this alkalosis, and instead your potassium is going to be introduced in the cell, taken from your blood, so it will lead to hypokalemia. This is in alkalosis. And also if you have external loss like diarrhea, dehydration, okay, or adrenal insufficiency. Sorry, or adrenal increase, because adrenal increase will lose, like in Cushing, you will do salt water retention and potassium loss. So this is hypokalemia. What is the manifestations of hypokalemia? Muscle and cardiac dysfunction, because this is the action of the potassium to function the muscle and cardiac. So there will be abdominal cramping, muscle weakness, and palpitations, arrhythmias, paresthesia, nausea, and vomiting. And on the ECG findings, what is the ECG findings of hypokalemia? ECG findings, you have no P, no T. You have no potassium, you have no T, and you wave, okay? So just remember two things. If you confuse yourself, you will forget everything. U and T, no P, you have no T. So if you have no potassium or hypokalemia, there will be U wave and T wave flattening. That's it. Treatment of hypokalemia is the potassium repletion, and don't use the dextrose fluids because they will stimulate insulin that will worsen the hypokalemia. Okay, and please remember always to check magnesium, because magnesium deficiency can be occult cause of hypokalemia. So correct hypomagnesemia as well. Okay, this is the hypokalemia. Okay. Hyperkalemia, when you have sodium above 5.5 or 5, they reverse the other causes like acidosis, beta adrenergic antagonists, insulin deficiency. So diabetes, beta adrenergic antagonists, and acidosis. And don't forget digitalis, because it will be working on sodium potassium ATPase pump inhibition. Don't forget the rhabdomyolysis will cause hyperkalemia. Exercise will cause hyperkalemia. It is cell lysis, muscle degradation. So they will increase the potassium, they will lead to hyperkalemia. So succinylcholine digitalis and the AC inhibitors, 3 drugs causing hyperkalemia. Also the same muscle and cardiac dysfunction, but there will be myalgias, muscle paralysis, chest pain and arrhythmias and palpitation, paresthesia, nausea and vomiting. The same symptoms, by the way. Okay, paresthesia, nausea and vomiting, the same for hypo and hyper, cardiac and muscle dysfunction, the same for hypo and hyperkalemia. You have simply wide QRS and big T wave. So hyperkalemia, remember wide QRS and big T wave. The potassium will take the T above by the thumb and index finger. Remember this. Treatment is IV calcium gluconate or IV calcium what? Chloride. 10 rule, 10-10-10. Why? Because this is stabilizing the myocardium, because you are afraid about the arrhythmias. So you give IV calcium gluconate as a stabilizer for the myocardium. So if you have hyperkalemia, don't think about potassium, but the heart. So give calcium, gluconate or chloride, 10% over 10 minutes. Okay. And also give insulin plus glucose and beta adrenergic agonists. So salbutamol, insulin, glucose, I say it GIS or IGS like insulin, glucose, salbutamol. Shift of potassium within the cells. This is a function. And give sodium in severe hyperkalemia, you might require dialysis. Don't forget these ones. Okay. Hypo and hypercalcemia, last 2 scenarios. Hypocalcemia, you have, what is the distribution of your calcium in the body? Do you know? What is the distribution of the calcium in your body? I need you to understand. Calcium and acidosis, alkalosis, calcium and hypoalbuminemia, calcium and everything like that. So calcium in your body, very important to understand what is the calcium distribution in your body, what is ionized, what is non-ionized, and all of that. Okay. Which is more active? Calcium, ionized or non-ionized? Which is the active form? The ionized, of course. Okay, what is the calcium distribution in your body? So simply the total body calcium is 1 kilo. 1 kilo. 1 kilo calcium, how? 1 kilo calcium and 1 kilo 0.3. 99% of them in your bones. That's why I'm saying kilo. And the other 1% in your body fluids. Okay? 1% only in the body fluids. 0.99% inside the cell of no reason in your blood. So no effect on the blood, it is intracellular. So remember 90-90. Kilo of calcium, 90% of it in your bones. 0.99% intracellular and only 0.1% in the extracellular fluid. Okay. A lot of them, or 50% of them, are bound to proteins. Half of this 50% to albumin, but we will consider 50 bound non-ionized and 50 free. Okay, remember again, kilo calcium or 1.3 kilo calcium, 99% of this in your bones, and only 1% of this kilo in your body fluids. 0.99% inside the cell, and only 0.1% what? In your body fluids, in the extracellular fluid, 0.1%. Half of them are bound to proteins, non-ionized, non-function. Okay. And the other 40 or 50% is free ionized calcium. So if I told you there is hyperalbuminemia, or let's say hypoalbuminemia. So if I told you hypoalbuminemia, the plasma-bound fraction of the calcium will be low, and the other will be free for you. So is it hyper or hypo? Hypoalbuminemia in liver disease will increase the free ionized active form of calcium, so will lead to hypercalcemia. Hypercalcemia. Very nice, very good. Okay, but what about alkalosis and acidosis and calcium? Do you know? Simply remember one sentence. Alkalosis promotes the calcium binding to albumin. So alkalosis hypocalcemic. Acidosis will promote freeing of calcium from albumin. So it is hypercalcemic. Very nice, very nice. So if you have alkalosis, you have hypokalemia, but you have and you have hypocalcemia as well. So alkalosis will need hydrogen to be outside the cell to the blood as compensation for it. So we'll introduce the calcium, will introduce the potassium inside the cell, leading to hypokalemia. Very nice. So it is, alkalosis is hypokalemic to the potassium. And alkalosis is promoting the binding of calcium to albumin, so it is hypocalcemic. Remember this, alkalosis is hypocalcemic and hypokalemic. Is it nice? I think it's nice. Okay. And yeah, for hypocalcemia, return back to hypocalcemia. So again, serum total calcium less than 0.4 milligram per deciliter. This is USA. The normal range for millimole will be given in your exam as UK. So decreased albumin can cause decrease in the total calcium, but a normal free calcium. Thus, the patient is asymptomatic in hypoalbuminemia. And ionized fraction of calcium should be less than 4.4. The etiology of the hypocalcemia: kidney, renal failure. I am the kidney. My function is to reabsorb as much as I can from the calcium. If I am in failure, the calcium will be lost in your urine. Vitamin D deficiency, hypoparathyroidism, hypomagnesemia, because hypomagnesemia inhibits parathormone release. Hypomagnesemia inhibits parathormone release. So again, what is the etiology of hypocalcemia? We said renal, hypoparathyroidism, vitamin D deficiency, hypomagnesemia, pancreatitis, and alkalosis. The presentation of hypocalcemia seizures tetany Chuvo-Stock sign, which is Chuvo-Stock ipsilateral muscle contraction caused by tapping on the facial nerve. And what is called the other sign is a Trousseau sign. Trousseau tourniquet. There is carbopedal spasm by inflating the sigmoid tourniquet above systolic blood pressure for several minutes. Yesterday, I was in part B lecture, and I'm going to share part of the new notes on your group, just to enjoy the hypocalcemia that came in their exam. Okay. This is a single question from one station. What is the studies? There will be QTC prolongation. And the treatment, if there is asymptomatic or chronic, oral calcium replacement therapy, such as calcium citrate or calcium carbonate. If low vitamin, give vitamin D supplementation. If there is hypoparathyroidism, give thiazides. Symptomatic patient, hypocalcemia, again, hyperkalemia, you give initially IV calcium gluconate, right? And in hypocalcemia, you give IV calcium gluconate. So again, in hyperkalemia, you have given IV calcium gluconate or chloride as a stabilizer of the cardiac muscle. In hypocalcemia, you will replace it by IV calcium gluconate. And for chronic renal failure, use phosphate binders and calcitriol and vitamin D deficiency. Okay. Hypercalcemia, serum total calcium above the normal, and especially the ionized, of course. It is the vice versa. So you will have hyperparathyroidism. Malignancy. So malignancy and hyperparathyroidism. Don't forget small cell lung cancer, which is there will be parathormone related peptide came in this exam. This will be paraneoplastic syndrome associated with squamous cell cancer and solid tumors, including lung, esophagus, skin. So we are going to post paraneoplastic syndrome to the group as well. Very, very important. You will have Min syndrome and paraneoplastic syndrome inevitable in your exam. Okay. Okay. Paraneoplastic to your group. Paraneoplastic syndrome. Paraneoplastic syndrome. Okay, paraneoplastic syndrome and others photos to your group, and also this one, this one, this one. Okay. Okay. Vitamin D overdose, hypervitaminosis D, like in sarcoidosis. So the presentation of hypercalcemia is, you remember, moans, groans, saccade. So it is kidney stones, so nephrolitis, polyuria, polydipsia, muscle weakness, bone pain, abdominal pain, secondary bowel hypoosmolality, and constipation, confusion, stupor, coma. So mnemonic is stones, bones, groans, thrones, increase the urinary frequency, and psychiatric moans or overtones, altered mental status. And shortened QT interval. Treatment, IV isotonic normal saline. Don't forget. So in hypercalcemia, the treatment was in hyperkalemia, when potassium is high, you given IV calcium gluconate or chloride. In hypercalcemia, IV normal saline. This will increase the urinary calcium excretion. Then you can think about bisphosphonates and calcitonin. The calcitonin will impair the bone resorption and increase the urinary calcium excretion. Bisphosphonates, like zolendronic for malignancy, and bamidronate is the most potent. So I say like that, zolendronic or zolendronate malignancy, and bamidronate is potent, the most potent. This has delayed onset of action, both of them, and impair the bone resorption, and this is a long-term calcium controlling drug, bisphosphonates. And you can use loop diuretics to increase urinary excretion of calcium. But don't forget, IV normal saline is the initial for hypercalcemia, and the IV calcium gluconate is the initial for hyperkalemia. Okay? So, is it clear for all of us? We've finished, by the way. Okay. So what is the answer? I don't remember now the answer. What is the answer was, Brianda?
Hello, yes, I said 0.9 sodium chloride A.
Okay. Thank you. Roa, if you are here, thank you, Brianda.
Thank
Keep
you.
going. Thank you. Roa, if you are here, Amr Anwar, Anishka, Mina, Mark always on the main group. Mark, the free group is containing 6,000 surgeons. So you are going, you are always asking on the main group. Like, they will feel that we are not here, okay? And we are neglecting you and stuff like that. So, okay, Mark. You can send to me direct, to my name, not the main group. Fana, Shumaila, Shah, Riham, مصعب. This is the recalls. يعني ده آخر فرصة. دي آخر قطر، آخر عربية في القطر. فيا تلحقونا ما تلحقوناش يعني. We need, this is the last car in the train.
Hello.
Roa, yes, go on.
A previously fit 21-year-old man collapsed while running a marathon. This patient is unsuccessful. Post-mortem examination show an intracranial hemorrhage. What is the most likely site of this hemorrhage? Extradural, intracerebral, intraventricular, subarachnoid, subdural. I will choose subarachnoid, yeah. It's immediate.
Revised neurosurgery on the group. Okay, next one.
40-year-old woman presents with 2 weeks history of flank pain and episodic frank hematuria. An ultrasound demonstrated 10 centimeter renal mass without hydronecrosis. What is the most appropriate investigation? We go for a computerized tomography CT scan.
Why?
Because there is an episodic frank hematuria and the 2 weeks history. So we want to see if there is renal injury or not.
CTUT. Is it with or without contrast? Without. CTUT.
Without, yeah.
Next one.
Previously fit young man is admitted after a road traffic accident. He is satisfactorily intubated because of head injury. He has a Glasgow Coma score of 8, E2, B2, M4. There are no other external injuries and initial cardiorespiratory stability is achieved during the primary survey. He suddenly becomes hypoxic after a log rolling to exam to the back. What is the most likely cause of his deterioration? The answer is E.
Okay, so when you have a patient and after trauma you manage to do everything for him, and suddenly without any intervention, so no traumatic pneumothorax, or suddenly the monitor showed hypoxemia. So this might be just the tracheal tube displaced. Next one.
21-year-old man has been hit by a cricket ball on his side of his head. Initially, he has Glasgow score of 15. 4 hours after arrival into hospital, while in observation ward, his GCS dropped to 7. His left pupil dilated and began to demonstrate extensive puncturing of limbs. What is the most likely change of his vital signs since injury? This is an increase in the blood pressure and heart rate decrease. It's a Cushing reflex.
So what is your answer?
It's D, yeah.
What is the triad?
It's hypertension and decrease in the heart rate and
وايه تاني؟
and decrease in the respiration.
طيب, now I need always to, I like to اسمها ايه؟ يعني اشرح يعني. I like to illustrate. Okay? يعني هو الحقيقة ان the normal cerebral perfusion pressure equals mean arterial pressure minus ICP. This equation came from Monry doctrine hypothesis that your brain is a closed box. Your skull is a closed box containing brain and CSF and other if bleeding or anything like that. So the control of cerebral perfusion pressure, the pressure that allowing the blood supply to the brain, equaling your mean arterial blood pressure. What is the mean arterial blood pressure equals? Anyone remembers?
And it's equal the stroke volume multiplied by the heart rate.
لا ده مش ده لا mean arterial pressure what equals
The systolic minus the diastolic. Either.
Okay, I posted on the group the MRCS equations. MAP equal diastolic plus 1/3 of the difference. يعني الماب ده بيساوي دي diastolic pressure, okay, plus يعني متوسط ضغط الدم مش ضغط الدم. It is a mean. So it is diastolic plus 1/3 of the difference of course we say diastolic systolic minus diastolic. ازاي يعني؟ If you have blood pressure 120/80, what is your mean arterial pressure? This is لو عندك ضغط 120/80 يا دكتورة رؤى، ايه المين بتاعك؟
93.
طب ازاي عرفت؟ قلنا here in the equation plus the difference. What is the difference? So diastolic is 80 plus 1/3 of the difference. ايه الديفرنس؟ 120/80 تطرحيهم من بعض 1/3 40. So 1/3 of systolic minus diastolic. Okay, so equal كام؟ 1/3 السيستوليك minus diastolic بكام؟
40 هنا.
So
40 هنا. 40
1/3 of the 40 plus 80. تلت ال 40 كام؟
30.3.
يعني 40 divided by 3, it is 13 point something, 0.333. So it is 13.
Plus
Okay,
80.
plus 80, so it is 90.
93.
This is the mean. So it will be here. Okay,
Mhm.
you will put 93 here. 93 minus, if I give you the ICB, what is the normal ICB? Like 12 millimeter mercury. Okay, whatever it is, 5 to 15 millimeter mercury. Okay, so I'm going back to the equation. So the equation said that if you have this hypothesis that's saying that your brain is closed. So if you have any reason for increasing the ICB, what should happen?
The CCP will decrease.
So if we said CPP equal MAB, and this is very important equation, and always I'm saying that this is very important equation, minus ICP. Okay, so if you have increased intracranial pressure, what should decrease or increase to make the CPP normal?
The mean arterial pressure should increase
Should
to
increase to
yeah.
make to normalize the cerebral perfusion pressure. So simply, if the ICP increase, what is happening to do this reflex here? And look at this one. When you have
will increase the heart rate.
yes, what happened? What will happen is that you have a vasomotor center. If you have raised ICP, the cerebral perfusion pressure will decrease. So there will be hypoxia in the brain. The hypoxia in the brain will activate the vasomotor center. The vasomotor center is sympathetic. Fire to increase the blood pressure because it is sympathetic vasoconstrictor. So blood pressure increase now. So you have the first one component of Cushing reflex is hypertension. Second one is that the vasomotor center is also close to the respiratory center. So there will be irregular breathing.
Breathing.
This is the second component, irregular breathing in your lung, okay? Additionally, the aortic arch baroreceptors will be stimulated. Baroreceptor connected to the vagus will lead to bradycardia.
Bradycardia.
So you have hypertension, irregular breathing, and bradycardia. This is the components of Cushing reflex. And don't forget, all what I said now is very important. So there will be hypertension and the bradycardia. Next one.
A 79 years old man who is a smoker with long history of esophagus present with dysphagia and weight loss. Endoscopy confirms presence of malignant structure. What is following is the most likely histological diagnosis. It's adenocarcinoma, adenosquamous carcinoma, lymphoma, epidermoid carcinoma, squamous cell carcinoma. It's adenocarcinoma before it's the lower third, and they try to stop this.
Oh, it was mute. Sorry. It was mute. So I will go back. So again, esophagus is originally lined with stratified squamous epithelium, right? So the cancer
Yes.
on top of it should be squamous cell carcinoma. Like in case of achalasia, there is a chronic irritation, there will be squamous cell carcinoma. So don't forget this. KKKK. Squamous cell carcinoma on top of achalasia due to chronic irritation. This sentence. GORD, gastroesophageal reflux disease, or GERD, will lead to columnar change from the stratified to columnar. Columnar is secretory, glandular. So adeno is a glandular carcinoma. So GORD, columnar metaplasia, Barrett's esophagitis, adenocarcinoma. Don't forget these ones. Next one.
24 hours after a routine aortic valve replacement for a heavily calcified valve, the patient's heart rate abrupt fall to 14 beats per minute. The systolic blood pressure, which was 140, is now 110, and the right atrial pressure, which was 7, now it's 15. Which of the following is the most likely diagnosis? Yeah, this is the Gojock sensitivity.
Sorry, what? Heart block, right?
Yeah, heart block.
Okay. Next one.
67 years old man is admitted to the history of fresh rectal bleeding preceded by the left side abdominal pain on 2 occasions in the past 36 hours. The blood was both bright red and dark colored mixed with the loose motion. He is on atenolol for hypertension. Examination show frank blood per rectum. There is a slight abdominal tenderness in the left upper quadrant and the left iliac fossa. He is normotensive with hemoglobin of 16 gram per liter. Which of the following is the most likely diagnosis? Anal carcinoma, ischemic colitis, lethal diverticulum. This is a classical presentation of ischemic colitis.
Okay, next.
A 25 years old man become constipated after taking opioids analgesic for back pain. Which of the following is the most likely description of his rectal bleed? Bright red associated with severe preanal pain. Bright red short-lasting episodes of perfused bleeding. Dark red associated with water stool. Dark red mixed with bowel motion. Dark red associated with strong smell. Associated with opioids, it's a bright red and severe preanal pain.
So simply, this is what? This is a bleeding from what? It is a fresh bleeding after fissure.
Motion.
So should be
Yeah, fissure.
bright red and associated with severe perianal pain. That's
severe pain.
next one.
50 years old man who's
sorry. In your exam, you will find per page about 5 questions, like or paper 1, you can find 20% very easy question can be answered by your son or your daughter. Okay, can answered by any medical student. Don't say, oh, the examiner is cheating me or deceiving me. There is a trick here. Don't think that like that. Don't be philosophic ولا اسمها ايه دي. اوكي، علشان الفلسفه بتضيع. يعني خلاص السؤال سهل، هو سهل، هحله سهل. ما تتوقعش ان الاكزامينر بيلف ويدور حواليك. In English, don't expect that the examiner is trying to trick you in each question. There are tricks, but the major is normal questions. So don't be panic of normal questions. And your first answer, when you don't know the answer, this should be correct. If you are going to change it, it's going to be wrong. Okay, 100% sure. If you don't know the question, you will not get a new knowledge from Ackland or from old man physiology or anything like that. So you are not going to be expert, and you don't know the question now. Answer any question. Answer any reasonable answer in your mind. If you answered it and you don't know why you are going to change it, it is very funny. يعني
Yeah.
انت دلوقتي جاوبت السؤال خلاص. هو السؤال يعني انت مش عارفه وجاوبته وخلاص، فانت عمال تقول ايه؟ عمال تحاول تفهم حاجه انت مش فاهمها وتعرف حاجه انت مش عارفها. فهتغير الاجابه ليه؟ ما انت اوريدي شكيت في اجابه وعقلك الباطن اداك اجابه. فبليز keep it, don't change it, because 50% is going to be correct, but if you will change it, will decrease this percentage. Okay, if you don't know the answer and the question and you put an answer, don't change your mind. Okay, next one.
A 50 years old man with type 1 diabetes and autonomic neuropathy undergo an inguinal hernia repair as a day case. Which of the following is the most likely to be a problem for him as a day case? Orthostatic hypotension.
Okay, so both reduced pulse rate variability and orthostatic hypotension are correct, but he's asking you as a day case surgery.
Day case. Mhm.
Okay, so it is answered last exam by a lot of people and they were convinced by a lot of answers, so they answered this one, but the correct is orthostatic hypotension. I'm afraid to discharge this patient not to fall, because diabetic autonomic neuropathy will affect the peripheral vasculature, lead to low vascular resistance, can lead to hypotension. Orthostatic one. Next one.
6 years old boy present with a 2-day history of right hip pain and inability to bear weight. On examination, he is apyrexial and systemically well, but his movements are generally painful. What is the most likely diagnosis? It's Perthes disease. Yeah.
Perthes disease. Okay, thank you, Roa. Anishka, Daib, Anishka. Daib, and then Anishka. Thank you, Roa. Thank you so much. Daib?
Yes.
Yes, go on. Go on.
Yes. 62 years old man present with painful bell right lower limb. Painful bell right lower limb. He underwent right. Please mouth can more popliteal below knee bypass 1 year and a half ago, using in situ vein double examination, graft is blocked. What is the most likely histological features of the graft? Aneurysmal dilatation, atheromatous plaque, non-intimatal hyperplasia, and small muscle hyperplasia, varicose dilatation of the vein. C, neo-intimatal hyperplasia.
New intimal hyperplasia. Okay, next.
Okay, and 6 years old woman with cecal cancer is blocked for elective right hemicolectomy. She otherwise fit and well. In the pre-assessment clinic, she asked about benefit of the enhanced recovery program. Which of the following is potentially benefit? Reduce the length of hospital stay, reduce the halt of chronic pain, reduce of use abdominal draining, reduce the use of nasogastric tube, using of morphine. reduce the length of hospital stay.
So it is very, very important to think about having ERAS. Search on the group ERAS, E-R-A-S, ERAS protocol. This is the Enhanced Recovery After Surgery program
Yes.
in the UK to enhance the recovery of the patient's post-op. It is a protocol of reducing tubes, drains, reducing the post-op hospital stay and post-operative pain and vomiting. Don't use IV opioids, use opioid-free analgesia, and try to eat as much as tolerated, eat and drink, and try to discharge the patient as much as you can, as possible as you can, if he is tolerating that, of course. And the tubes, drains, reduce the tubes and the drains, try to reduce them earlier. And also don't forget minimally invasive surgery is better. Tubes means drains or any abnormal analgesia type, which is extra away from the normal oral pathway. Next one.
40 years old woman feel a sudden pain in the left leg and feels as if the if she has been hit in the back of the ankle as it started to cross the road before she fell. Which of the following is the most appropriate clinical tests? Okay, and Benjamin sign, a place grand test, Flanis maneuver, Smythe squares test, Thomas test, D, Simon squares test.
Simon's squeeze test. Excellent. Rupture of Achilles tendon, Simon's test. Okay, next one.
And after returning to the United Kingdom for the business trip to China, one 35 years old woman is admitted to hospital with painful swollen right leg and unpalpable dorsal speed pulse and double ultrasound sonograph of the right femoral vein showed extensive mobile thrombus. The most appropriate immediate management would be aspirin exploration in the femoral vein, heparin, left compression, thrombosyparin. Heparin.
Hypernization is the
Yes.
correct answer. Okay, next one.
And 68 years old woman present with 2 months history of intermittent blood standing nipple discharge from her right breast. There is no significant past history clinical examination. Confirm presence of blood standing nipple discharge, but show no palpable abnormality. Mammograph and ultrasound scan and are normal. What's the most appropriate next step in the management? A clinical follow-up in the 3 months. Doctogram, reassured patient and discharge, surgical exploration, tamoxifen. Answer is B.
The answer is dactogram. We have
Doctor.
changed this. Yes, according to the diagnostic nipple discharge here, you are not going to reassure the patient, no, because the discharge, but you are going to go for extra investigation. Okay, so dactogram will help you to know the duct that needs to be removed before doing, because you have no, when you do surgical excision of the affected duct, how would you know the affected duct? So if you look at the group last post on the group, you need to do ductogram. Salwa, I think you've got some experience in that. So regarding your specialty, so is they doing ductogram? I have a liaison with the some of the breast team, and they recommended ductogram to be the answer. Next step in management, not the most appropriate or the definitive management. So next step is a ductogram. Okay. Next one. Thank you, Dr. Daib. Thank you so much, Anishka. Thank you, Daib. If you just go to away again, Dr. Daib, I'm sorry for this, but if you will go away from the noisy background, we can have another session because you have a short one, because the background is so noisy. But okay, Amr Anwar, please raise your hand. Thana, Sora, Tajul, Z, Mark, Nia Bakri.
Hello?
Yes, hello.
Hello, sir. It's Anshika.
Yes, Anishka, go on.
A 24-year-old man with a history of Crohn's disease presents with generalized bone pains and tenderness in his thighs. He also has increasing muscle weakness, increasing difficulty in walking, and a change of gait. Serum calcium and phosphate levels are low, but alkaline phosphate and parathyroid hormone levels are elevated. A bone biopsy shows increase in non-mineralized osteoid. What is the most likely diagnosis? Osteomalacia.
Okay, so it is simply vitamin D deficiency, rickets in children, and osteomalacia in adults. Next one.
A 32-year-old woman with a recent diagnosis of Graves' disease underwent incision and drainage of a breast abscess 3 hours ago. She has become agitated, confused, and is noted to be jaundiced and sweaty. Her temperature is 39 degrees Celsius, pulse is 152, and blood pressure is 95/60. ECG shows an irregular ventricular rate with absent P waves. After resuscitation, what is the most appropriate next step in management? Beta adrenoceptor blockers and thionamides.
Beta blockers and thionamides. A lot of people answer this one, but I told you beta blockers and thionamides. Types of shock.
Types of shock.
No, not for you. Not for you. Because I'm going to have a short discussion about types of shock in 1 minute. Thank you. Sorry, Anishka.